Thank you. You've all sat at the back. I hope you're interested in the topic. My background is computer systems engineering, and specifically safety critical systems engineering. And I've been in Warwick for about 10 days now. Before that I was in York. But I've been working on safety of health IT, mainly with the NHS, the ex-CFH, now Health and Social Care Information Centre. So this is a little bit of summary and introduction of the problems that we highlighted based on the work with the NHS. So a little bit on the problem and the background of safety of health IT. So safety is about events, bad things happening to people. In other words, killing people without wanting to kill people. And then we distinguish safety from security because safety does not have any malicious intent. So we do use risk as a metric, as an attribute to describe unwanted effects. And risk has two constituent qualities. Likelihood of an event, so it is something happening every day, every week, every month, and how bad that event is, the severity of that event. So is it injuring someone? Is it a death? Is it multiple deaths? So depending on the range of that event in these two dimensions, according to these dimensions, we classify the events according to risk, so higher risk and lower risk. Now about health IT, there is consensus on the benefits of IT. So they make treatment healthcare more effective, we can help more patients within the same time. We have actually reduced errors, we have reduced risks. For example, the prescription systems is a very well documented case where use of health IT has improved safety because using IT systems we've taken care of human error. However, that risk reduction process, actually introducing health IT into healthcare, may introduce risks, new risks. Risks that have to do with the software, risks that have to do with the systems that we're using. And actually, we need to understand these risks. Do we need to have the risks? Is it necessary for these risks to be present? We need to analyze the system, we need to understand these risks, and at the end of the day, if we can't do something about it, if there's little money involved and little effort involved to improve the safety of the delivered healthcare, we should do it. So in other words, we need to remove any unnecessary risks present. So we need to understand the risks present, we need to classify them, we need to understand what it takes to remove them or reduce them, and actually we need to remove them or reduce them to an acceptable level. So we have various types of risks. We have many large systems collaborating, we have multiple data representations, results from exams of the patients, we have storage and interchange formats, we have images and CAT scans stored digitally now. We do contract systems and IT from different vendors, so sometimes these systems may not even know how to talk to each other, so we can't just connect everything together. Different technologies, so we can have a wide spectrum of risks, of things that can go wrong. So we could have duplicate records with information splitting into records, wrong dosage, delays in treatments, monitors blacking out or freezing during treatment of the patient. So we need to understand how this will affect the delivered healthcare. So there is a very notorious case, the London Ambulance Service case, which is one of the most well-known examples. So what they did, they realized that by using more automation, more information systems to dispatch ambulances, they could improve the delivered service. However, the contract was given to the lowest offer without actually understanding the competency of the contractor, And they had a number of problems. They had exceptions, so windows popping up saying something went wrong, and here's a very fuzzy code, and 356 is the error that you've done, and go find the solution in 1,000 pages of manuals. Many delays. Operators did not know what to do, and actually, I don't know if you can read it, but the backup system was not fully tested. So they actually deployed the system without testing the backup. Hours after development, so everything descended into chaos, an ambulance found the patient dead and taken away by the undertakers. Another ambulance answered the stroke call after 11 hours, 5 hours after the patient had made their own way to the hospital. So you can see how this is a very easy case to see how IT may affect the safety of healthcare. In hindsight, they should never have had assurance in the operation of the London Ambulance Service. But there is the question, how could they have known? What can we do to know in advance that something is right to operate, safe to operate, or unsafe to operate? It's this confidence that we have in the system that safety of IT is all about. This is a study made by the ECRI Institute. I can't remember what the acronym stands for. I'm not very good with acronyms. But if you want to look it up, you only need to search for ECRI PSO Deep Dive. That's the name of the report. And actually, they've identified a number of IT-related events, and they classified the events according to criticality, harm score, as they call it. So you can see here that about 2% of the events may have contributed to or resulted in patient's death. Another 2% error contributes to or results in temporary harm. There's another 1% that error required some intervention to sustain life. So overall, about 6% of events had an adverse effect on the patient. So there is the events related to IT cannot be taken lightly. So about 5% may affect seriously, significantly, the health of the patient. Now we need to understand what we can do about this 5%. How much of that 5% can we improve? And actually it's not one single IT system, because they made a classification according to various IT categories. So they have clinical documentation systems, they have pharmacy systems, laboratory information systems. So it's a wide variety of systems that contribute to these events. So the problem is everywhere. It's not a single type of system. So this is another example that I like to use. It's sort of abstract example, but it's a real one. So this is an A&D admissions table, the window of the IT system. So I'm not sure you can see it at the back, but we have the name, surname, time of arrival, whether they have been assigned to a doctor, whether they have been examined by a nurse initially to do the triage, and the criticality. So from a first look, there's nothing wrong with it. It's just a window, a software window. But if you notice, there's a line hidden there. So if we scroll down, that line was someone that needed urgent treatment, who had not been assigned a doctor and had not been examined. And maybe they missed it because it wasn't visible on the window. So what do we do about it? Do we implement a procedure that says, the nurse who operates the system needs to scroll up and down all the time to make sure that they have not missed someone? That's not a very that's not a measure in which to have a lot of confidence. And there are other issues. We have an entry here. We have a Tom Smith and Tim Smith. Was that a typo? Was it actually two different people with the same surname arriving at different times? Because one has been classified as having something that's highly critical, and the other one with low criticality. So which is it? Are we certain that we haven't made a mistake there? And actually there are many ways in which we can address this issue. We could actually ask the nurses to scroll up and down all the time. We could go back to the manufacturer and tell them, yes, I need to have the function to click on the criticality and sort by criticality, or even some sort of color-coded functionality to show the urgency in red perhaps. So these are the measures that we take, these are the safety controls that we design into the system to address this kind of issues, to increase our confidence that we will not miss anyone. So let's have a look at regulation and practice, and actually motivation behind all this. First one is legal issues, duty of care when you deliver health care to the patient. We have ethical issues. Okay, that's sort of straightforward, why we need to implement safety or care about safety. And actually, currently, there's a lot of momentum towards safety of systems in healthcare. We have ISO standards on medical devices, and actually many manufacturers now will do the CE mark, which is not quite explicitly about safety, but it's one step towards that way. We have an ISO standard on interconnected systems and devices that are used in health environments. And then we have the safety of health IT standards by the NHS, the Health and Social Care Information Center. These are the two ISB standards, information standard codes 0129 and 0160. One refers to the operator, for example hospitals and NHS trusts, and the other one refers to the manufacturer. And actually all NHS trusts implementing e-health or health IT must comply to this standard. It's a mandatory standard. But unfortunately, not everybody knows about it, which is quite bad. So what do these two standards say? Actually, they ask for an explicit explanation of safety. So they need to be convinced. They ask the operator to argue how, based on available evidence, we can confidently claim that the system will be safe. That's the main principle of these two standards. It's fairly straightforward. We need to provide an explanation to a third party as why that third party should have confidence in the safe operation of our systems. And when we talk about evidence, we mean testing results, code reviews, procedures, independent audits, expert opinion, anything that might increase our confidence in the safe operation of the system. Quite often, this is seen as a lot of overhead for both the manufacturer and the operator. However, this is information, all this evidence that these two standards ask is information that a good manufacturer ought to produce anyway. So I can't imagine a manufacturer implementing health IT not doing any testing or a code review. It should be there somewhere. It's just a matter of actually picking this information and creating an argument, saying how this information enables us to make a claim about the safety of the system. We need to connect the dots somehow. If the evidence is not there, then perhaps you ought to find a different manufacturer. This is also known as safety justification, assurance case, or a safety case. All these terms point to the same concept. So when we ask someone, why should we believe that your system is safe? We have a number of answers to give. So we can say, it costs a lot of money, therefore it's safe. Okay. I analyze the risks to the service or the pathway, so I understand how the systems contribute to the service that I offer. That's a better answer. I know what I'm doing. I've been doing it for 20 years, so I'm pretty good. Oh, by the way, there's a new technology that I use that I'm not familiar with, but yeah, other than that, I've been doing it for 20 years. I comply to ISO 9000. That's a good one, because compliance to quality standards do not explain safety, they imply safety. So they make the assumption that because we followed good processes, we have a safe system, which is a bit of a leap actually. We need to understand the risks explicitly. But compliance to quality standards do help. I have introduced safety controls, safety functions, so explain what you did. So for example, I've introduced a function that highlights, uses a color code to highlight the urgency of someone that needs to be treated. Many people do not know what you ask, so they give you documents, random documents. This is my safety case. Okay, I have testing results. They did a lot of testing, but evidence by itself does not really explain anything. Just giving someone evidence leaves safety unexplained. We need to explain how this evidence will allow us to conclude that something is safe. And then we have the other one, the last one, where people are offended. Having spent 13 years in York, this is the Yorkshire defense, I can tell you. So the correct answer is not any one of them. It's a combination, actually. Sometimes you'll be able to point to testing results. Sometimes you'll say, yeah, that's not a very important concern. It can go wrong only once every year. So, yeah, I've done a good job. I complied to ISO 9000. That's good enough. So our safety case usually is a mix of all these arguments. Now the challenges. Firstly, we need to appreciate the IT-related risk. And by appreciate, I mean being aware of it and make other people aware of it and actually understand it. Just knowing that health IT may result in patients' harm is not good enough. We also need to understand how, and we need to do something about it. Management will always resist that. They'll say, I don't have the budget, I don't have the money. So all you need to do is ask them to sign off something that says that we don't know if our system is safe or not. It's that uncertainty that we're trying to deal with. So if you tell them that I don't know if something is safe or not, and by the way, you have to sign it off. It's a convincing argument. Competency. We need to know how to do this kind of analysis. So I've heard stories where people delivered, manufacturers actually, gave a 3-page table with some hazards on the table saying this is my safety case. Well, no, it's not. Not by any standard. Procurement of IT systems. Because we're going to refer to testing evidence, data, code reviews, we're going to have an ongoing relationship with the manufacturer. And it's good to realize that during procurement, to set up the appropriate communication channels, because you're going to need the manufacturer after deployment of the system. If the contract is just, here's the box with the software in it, install it and that's fine, you're going to be in trouble. Then it's going to be very, very expensive to go back to the manufacturer and ask them for extra functions, extra testing perhaps, or anything. And that's why many times hospitals are sort of put in a position to develop their own software on top of software that they've just contracted. Explanation of testing results, so we need a way to explain it. Use of tacit knowledge. Well, if you do some sort of safety analysis or you want to understand the impact of health IT on safety, you need to involve everybody. So the nurses, the doctors, everyone who's involved in the service and delivery of that service, because they have that tacit knowledge, that's something that may be going wrong and they've taken shortcuts. Oh yes, this has been happening all the time, but it's easy to fix. Okay, maybe it's easy, maybe it's not, maybe you haven't appreciated the risks completely. We need to capture this tacit knowledge. And finally, we need commonality of practice. Whenever we talk about risk, whenever we talk about safety cases, we need to understand the same things. And actually, about risk is quite important because many hospitals, many manufacturers use different risk standards. So they say that something is severe and they mean a paper cut, someone else means severe and they mean a patient being injured severely. Finally, if you're interested in all of that, it's a topic of research that I'm following at the moment. We are interested in your experiences, anecdotes, examples, problems. There is a LinkedIn group, Safety of Connected Health, that I set up some time ago. And actually I've organized a conference on safety, a workshop, not a conference, on safety of connected health. I think these ought to be dedicated events and usually, with the exception of the presentations, we run them under Chatham House rules. It's easy to understand why. And actually I'm trying to set up, as part of this series of meetings, a talk from the guys from the NHS in Leeds to come and talk to you about ISBs if you think it's an interesting topic or you need more information. Right.